few questions on that. There we go. So yeah, just a variety of projects. I've got a project that we're running to understand what's the optimal duration of antibiotics.
Yeah.
Because we have so little information guiding that at the moment.
It's
Yeah,
also make me shocked, Dr. Fergus. We have little research in our teaching hospital. So I work in veterinary faculty of Universitas Airlangga. So we do with our students a little data for all of the patients who comes to our veterinary teaching hospital. We found more than 30% that had antimicrobial resistance, which shocks me. Yeah. Especially resistant of ampicillin. Yeah, ampicillin.
Really?
Yeah, ampicillin.
Okay. Yeah, I mean, I think that's the worry, and that's really why we're talking today, isn't it? As to how common resistance is becoming around the world. So, yeah, it's worrying if you're seeing resistance to those common antibiotics too frequently.
Dr. Fergus haven't been to Indonesia, Doc. So maybe we should invite him.
Yeah,
sometime.
maybe next time.
Yeah, I'd
try
love
to.
to come one day.
Okay.
Very, very keen.
Thank you very much. What about the antibiotic use in large animal in England?
It's come down a lot, so it has improved
Yeah.
dramatically. Particularly in pigs and poultry,
Yeah.
they've been able to bring those levels down by about 80 to 90%. But they started from a bad place. They were overusing them a lot, so they had a lot more room for improvement. I'll show some of the figures for cats and dogs in the UK, which is disappointing.
Yeah.
In the UK, it's quite disappointing that we don't seem to have made much improvement in the last few years. So I think there's still a large opportunity for us to improve the way we're using antibiotics. And I will be talking pretty much exclusively about cats and dogs. That's okay,
Cats
is
and
it?
dogs.
Yeah, you're happy with that?
Thank you, Doctor. Maybe you can we can turn the camera off and wait.
And we wait for.
Thank you.
Thank you very much. Kita sambil nunggu Dr. Moon ya.
Yeah.
Suaranya belum muncul, Dok.
Suara saya terdengar kan?
Sampun, sudah.
Belum terdengar, Dok?
Sudah, silakan.
Ya, baik. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua. Om Swastiastu, atas nama budaya, salam kebajikan. Selamat malam dan selamat bergabung di acara webinar Antimicrobial Stewardship in Small Animal Practice yang diselenggarakan oleh AKIVI, Asosiasi Kedokteran Internal Veteriner Indonesia. Dan saya, Dr. Hewansi Wahyuni, merasa sangat terhormat dapat menjadi bagian dari acara pada malam hari ini. Terima kasih kami ucapkan kepada seluruh teman sejawat, kolega yang telah meluangkan waktu dalam ruang online kita pada malam hari ini. Dan terima kasih juga kami ucapkan kepada Ketua PBPDHI Dr. Hewan Muhammad Mundawarah MM beserta jajarannya yang telah meluangkan waktu untuk hadir bersama kita pada malam hari ini, kepada Ketua AKIVI Dr. Hewan Nusdianto Triakoso MP beserta jajarannya juga, dan tentunya we warmly welcome Dr. Fergus Allerton, and thank you for joining us as tonight's speakers. Thank you very much, Doctor. And then selanjutnya itu tentang resistensi antibiotik adalah merupakan masalah yang telah lama digaungkan dalam beberapa dekade terakhir. Lalu bagaimana seharusnya kita sebagai dokter hewan praktisi dapat berkontribusi dalam menurunkan risiko AMR yang ada di sekitar kita, atau bahkan mungkin kita yang justru malah menyumbang potensi AMR di lingkungan kita. Mari kita kupas tuntas bersama narasumber kita nanti, yakni Dr. Fergus Allerton. Memasuki acara pada malam hari ini, pertama-tama mari kita mulai dengan membaca bismillah. Kemudian selanjutnya yaitu menyanyikan lagu Indonesia Raya, dan selanjutnya akan menyanyikan lagu Mars PDHI. Kami mohon agar semua peserta dalam posisi mute dan mengikuti dengan hikmat.
Belum di share sound mungkin Dokter Yuni.
Suaranya belum ada, Dok.
Baik, terima kasih atas kesediaan Bapak Ibu kolega dalam partisipasinya dalam menyanyikan lagu Indonesia Raya. Selanjutnya yaitu menyanyikan Mars PDHI. Baik, selanjutnya acara selanjutnya yaitu sambutan-sambutan. Sambutan pertama akan disampaikan oleh Ketua AKIVI kepada Dr. Hewan Musdianto Triakoswante. Disilakan dengan hormat. Silakan.
Terima kasih Dr. Yuni. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Salam sehat, salam sejahtera pada semua sejawat. Alhamdulillah, segala puji syukur atas nikmat Allah Subhanahu wa taala, Tuhan semesta alam telah memberikan kesehatan dan kesempatan kita bisa bertemu di momen yang sangat luar biasa malam hari ini. Saya sampaikan apresiasi Dr. Munawaroh, Pak Ketua ini sangat sibuk dan beliau berkenan untuk bisa join bersama kita malam hari ini, setidaknya untuk kami minta untuk memberikan sambutan dan membuka acara, karena acara ini kami anggap sangat penting, ya, dengan persiapan yang sangat singkat, mudah-mudahan akan bisa memberikan manfaat yang luar biasa. Saya juga sampaikan terima kasih yang setinggi-tingginya. Thank you very much, Dr. Fergus Allerton. Yeah. Thank you for joining with us, yeah, for sharing your knowledge about, especially about antimicrobial, yeah, stewardship, yeah, to increase our awareness about the uses of antimicrobial in Indonesia, especially for our veterinarian in small practice area. Yeah. Thank you very much. Yeah. Dan sejawat yang saya hormati, ini adalah topik yang sangat menarik. Kebetulan beberapa waktu yang tidak lama, jadi persiapan kami sama sekali sangat cepat ini. Dr. Deon mampu untuk menyiapkan kegiatan ini dengan sangat singkat. Ya. Kami mencoba untuk menyampaikan beberapa hal yang kami anggap penting, terutama adalah kekhawatiran atau keprihatinan kami terkait dengan antimicrobial resistance, terutama di Indonesia, di banyak aspek. Ya. Nah, kami undang Dr. Fergus Allerton. Beliau adalah pakar yang terkait dengan antimikroba tadi itu, untuk bisa membagikan pengetahuannya, ya, terkait dengan penggunaan antibiotika dan khususnya kewaspadaan kita yang harus kita tingkatkan untuk mencegah semakin meluasnya kejadian resistensi antibiotika ataupun antimikroba secara keseluruhan nanti, begitu ya. Nah, topik yang sangat menarik ini, ya mudah-mudahan bisa diikuti. Sepertinya memang sangat banyak tertarik, karena dari pendaftar itu ada hampir lebih 310. Tetapi memang enggak tahu, mungkin mereka belum terbiasa dengan pola kegiatan webinar di AKIVI, sehingga sebagian tidak melanjutkan untuk register di Zoom. Mungkin sekitar ada 200 registran yang di Zoom, dan sementara barangkali juga yang bergabung di webinar malam hari ini sekitar 77 peserta, tidak ada masalah ya. Kami ingin berbagi pengetahuan tadi itu untuk meningkatkan pengetahuan kita tentang penggunaan antibiotika, supaya kita bisa mengambil langkah yang tepat bagaimana penggunaan yang benar dan mencegah terjadinya resistensi antibiotik. Ya. Demikian barangkali yang saya sampaikan, mudah-mudahan acara yang luar biasa tadi itu bisa memberikan manfaat pengetahuan yang tinggi. Dan selanjutnya kami mohon Bapak Ketua Umum Dr. Muhammad Munawaroh untuk bisa memberikan sambutan sekaligus membuka kegiatan kami pada malam hari ini. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih Dok atas sambutannya. Sambutan kedua yakni dari Ketua PBPDHI, Dr. Hewan Muhammad Munawaroh MM, kepada Dr. Hewan.
Baik, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Yang pertama yang saya hormati Ketua PNT AKIVI, Dr. Hewan Musdianto. Yang selanjutnya saya hormati para peserta yang hadir pada malam hari ini. And special thank you very much for Dr. Allerton, Fergus Allerton. Yeah. Thank you very much for joining in this seminar. I think the topic is very important for our members in Indonesia. Regarding for antibiotic microbial resistance, this is the issue for international issue, also national issue. We know that from WOA, World Organization Animal Health, and also with the WHO, the prediction if the antimicrobial resistance not to be prevented will be maybe more than 10 million people will die regarding the antimicrobial resistance. So I think it is very important for us to know how to protect our public, our people in the world, yeah, how to protect from antimicrobial resistance. So must we know how to use the good use antibiotic for veterinarian, yeah, also in the farmer, in the livestock, in the dairy co, in the cattle. So it is very important. So I think this discussion will be very important for us. Thank you very much for Dr. Fergus Allerton. You can sharing your knowledge to our member. Itu ya. Saya pikir dengan mengucapkan Bismillahirrahmanirrahim, acara seminar webinar hari ini yang diselenggarakan oleh AKIVI, alhamdulillah bisa kita hadiri oleh paling tidak minimal 100 orang yang hadir pada hari ini. Saya nyatakan dibuka. Wabillahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih.
Terima kasih dokter atas sambutannya dan kesediaannya telah membuka acara kita pada malam hari ini. Dan selanjutnya yaitu memasuki acara inti di mana Dr. Fergus Allerton akan memaparkan kepada kita tentang mengenai antimicrobial resistance yang terjadi pada small animal practice. Dan pada acara ini akan dipimpin oleh atau dimoderatori oleh Dr. Dewan Kristiawan. Kepada Dr. Dewan Kristiawan, kita persilahkan dengan hormat.
Terima kasih Dr. Sri Wahyuni. Okay. Good evening, dear college, fellow veterinarian from all over Indonesia. Let us introduce our speaker for this AMR webinar, Dr. Fergus Allerton. Thank you, Doctor. He is a specialist for small animal internal medicine. Dr. Fergus graduated from University of Bristol in 2004 and then completed his residency in Belgium, where he earned his diploma of European College of Internal Medicine. He currently works in Willow Referral Service, also at Innovet. Dr. Fergus was involved in the development of the PROTECT-ME guidelines for the proper use of the antimicrobials. This year, Dr. Fergus gave a passionate presentation at the World Small Animal Veterinary Association in China, and it's such an honor to be able to invite Dr. Fergus in front of Indonesian veterinarian. With great pleasure, I'm inviting Dr. Fergus to take the stage for the presentation. Thank you.
Thank you very much for this generous invitation. I'll try and share my screen and see if this works. So hopefully that you can see that okay?
Yes, okay.
Perfect. Right. So today's talk is going to be about antimicrobial stewardship, but just because we're talking about the best way to use antibiotics, it doesn't mean that we're anti-antibiotic. In fact, we have to recognize that these are an amazing resource. Antibiotics have saved countless human lives and probably reduced suffering and improved the health of a lot of animals that we treat as well. And I've just put up a couple of key historical dates. The reason I've put them there is because you can see penicillin discovered by Sir Alexander Fleming, pictured there in 1928. They didn't initially realize its potential, and it was not until 1939 that Chain and Florey started using it in vitro. And then the first human treatment, 1941, and it wasn't until 1945 that it got into mass production. And I've put those dates because look at the date for the identification of the first bacterial penicillinase. That was 1940. So before we started using antibiotics in that way. And this reflects a constant, a long-standing arms race between bacteria and the other microorganisms that produce antibiotics to try and gain that survival advantage. We are now contributing to the acceleration of that arms race. And antimicrobial resistance is a massive, massive threat to human and animal health. Our colleague earlier on highlighted figures from Lord Jim O'Neill's study that suggested that by 2050, so within a generation, we could be seeing 10 million people dying per year due to multi-drug resistant infections. A study published in 2022 that looked at data from pre-COVID found that over 1 million people died due to multi-drug resistant infections, and getting on for 5 million people died in association with multi-drug resistance. This is already a serious issue for human health. And why is this becoming such a big problem? Well, because we are contributing to increasing antimicrobial resistance. Every time we use an antibiotic, we increase the exposure of bacteria to those antibiotics and the likelihood that resistance will develop in that environment. Antibiotic use is probably the primary driver for antibiotic resistance. And that means it is vitally important that all antibiotic use is appropriate. It's needed for that animal to improve its health and avoid suffering. But in the UK, where I work, 1 in 4 dogs, 1 in 5 cats receive an antibiotics roughly every 2 years of their life. And a significant proportion of that, especially in cats, is the most important type of antibiotic. We'll talk more about categorization a little later on. But that strikes me as quite a lot of antibiotics going into the pets that we're treating. And I wanted to offer a visual demonstration of antimicrobial resistance developing. This is taken from the Kishoni lab at Harvard University in the United States of America. And they've taken a Petri dish. This is a table-sized Petri dish, so an enormous Petri dish. And on that Petri dish, they have instilled different concentrations of antibiotic. So at both edges of that Petri dish, there's no antibiotic. And then there's low concentrations, medium, moderate, and high concentrations of the antibiotic in the middle. And what they're then going to do is they're going to plate this Petri dish with some bacteria. And that's E. coli, a common antibiotic we see in practice. And let's see what happens. This is a film that is taken over it's time-lapse photography. It doesn't last the whole 9 days that they filmed this, luckily, but it's going to show what happens. And what you can see is that at the edges of the plate, the bacteria quickly grow. There's no antibiotic there, nothing stopping them. But suddenly, and in multiple different sites, you can see bacteria are now growing where there is antibiotic. So mutations have occurred within those bacterial populations, allowing them to survive where the antibiotic is present. And they will quickly then, now that they can survive, they'll grow across that part of the plate. They aren't slowed anywhere near as much when they hit the higher concentrations. So it's 10 times more antibiotic, but really causes a very small pause in that bacterial march across the plate. And by the end of this filming process, the bacteria were surviving, were flourishing in antibiotic 10,000 times the concentration of what we would normally be using. So this is a scary thought. Bacteria can do this in a Petri dish. We're using living Petri dishes every time we use antibiotics and we give them to dogs and cats. There is the risk that this resistance process will occur and develop among the bacterial populations within those organisms. And that could pose a problem for us in the future. So knowing this risk, are we getting better at the way we're using antibiotics? This data was published in the UK a couple of weeks ago, earlier in November. And what it shows is the amount of antibiotic given to cats and dogs in the UK over a year. And you can see that since 2015, there has been relatively little improvement in the quantities of antibiotics going into those species. So despite this awareness, we still have a lot of work to do to improve our antibiotic use. And we can break that antibiotic use down by particular agent. And I've put this data up because I don't know exactly which antibiotics are most commonly used in Indonesia. But in the UK, amoxiclav, so potentiated amoxicillin, is the most commonly used antibiotic. And that accounts for over half of all antibiotic use in the country, and especially in dogs. In cats, we still use about 50% amoxiclav, but we also use a worryingly large amount of a drug called cefavecin, which is a long-acting third-generation cephalosporin. We use it as a one-off injection, and the manufacturer will suggest that that can last up to 10 to 14 days. Now, it's a nice product in terms of that duration of effect, but we worry that its selection may drive a resistance problem, and resistance to a very important antibiotic, one that we would like to reserve for human use. So we need to think not just about changing the amount of antibiotic we use, but also changing the type of antibiotic that we reach for. As Dion kindly mentioned in the introduction, I was involved in the development of the Protect Me poster. Now, this poster is freely available. It can be downloaded from the BSAVA website, and we would encourage anyone who is interested to download a copy, print it off, and put it on your practice wall. And if anyone's interested and has those linguistic capabilities and would like to organise a translation, that may be something for the future. We would love to support people having this in a language that is more familiar and more accessible to people. The poster can be broken down into different sections. Protect Me is actually an acronym, and each letter corresponds to a different recommendation, a different way to manage antibiotic use. And all these little boxes you can see contain specific organ system recommendations. So, for example, for gastrointestinal disease, we suggest when antibiotics can be used, which antibiotics should be selected, and how long it should be used for. So you might be seeing an animal, say a dog with a urinary tract infection. You can refer to the poster and see which antibiotic would be the most appropriate to select and how long to use it for. And there is other information buried in there as well that is hopefully useful and can help you when you're in a high pressure, low time situation. Protect Me isn't the only guideline out there, so there are a whole variety within Europe alone. And these are listed here, and depends whether what your language skills are, but you can see that the French, the Italians, the Swiss have all come up with their own sets of guidelines. And there's also things like the Gram book, the Danish guidelines. These are freely available, so they're accessible to all. And if you want to have a read of them, you can learn a lot more about this very important topic. There's the Turkish guidelines there, and some different versions of guidelines from Italy. Protect Me, though, does try and encourage vets to prescribe only when necessary. This is to try and get away from that just-in-case habit. I'm worried that that dog may have an infection. I'm not sure, so just in case, I'm going to give them an antibiotic. Is that good enough? Should we be accepting that approach, or should we make that bar higher? Should we say, really, you've got to prescribe an antibiotic only when you are confident that it is needed, that that animal will benefit from that drug, not as a just-in-case approach? Because there are alternatives to antibiotics, things that could actually support the animal getting better if they don't have bacterial disease. So if it's a viral condition, it might be that the animal benefits from just rest and anti-inflammatories that will help it recover in due course. We want to make sure that we optimize dosage protocols. I'm going to talk a little bit about antibiotic course duration in a moment. And another key tenet is to try and encourage vets to collect samples for cytology, so looking under a microscope and seeing if we can see bacteria there, and culture to prove the need for those antibiotics and make sure we're selecting the right one. I wanted to fire out a sort of hypothetical situation, and this highlights the different approaches we have at the moment in veterinary and human medicine. So the first patient is a dog that I might see living here in Birmingham. It's a West Highland White Terrier, a little white fluffy dog. And the dog has a 3-day history of diarrhea with a bit of blood in that. Okay, and the owner tells you, this is not the first time the dog's had this problem. I've had to come to see your colleagues before, and each time he's been given a little course of antibiotics and he's got better. Do you think that dog is going to leave the consultation with an antibiotic? And let's compare that situation to one that we might envisage in human medicine. And this is a child living in Bangladesh who has profuse watery diarrhea, and that's causing moderate dehydration. And the child tells the doctor, actually, a few members of his family have been diagnosed with cholera. Just in case, for anyone who's not familiar with cholera, it is a bacterial infection. It's one that gets better quicker with antibiotics, and you would reduce the transmission if you gave antibiotics. So should that child receive antibiotics? And we can ask different sources as to what's likely to happen. So the World Health Organization provide guidelines helping doctors working in those situations to make the best decision for that particular child. And they will encourage you to assess the dehydration status, to rehydrate and provide fluid resuscitation, whether that's orally or intravenously, and maintain that hydration support to compensate for ongoing fluid losses. But they will only recommend the administration of an antibiotic to people with severe dehydration. So this child, who was only moderately dehydrated, would not qualify for antibiotics at this stage. And I wrote to the World Health Organization, I said, why do you impose those recommendations? And they said, because it's for stewardship. We are trying to protect that antibiotic so that it will be effective for patients who really, really need it. That child is likely to get better on their own. They do not require that. They require the fluid support, but they should be able to clear that infection with their own immune system. So they are keeping that antibiotic in reserve for people who are really struggling and who wouldn't manage without, because they want to preserve its efficacy. Do you think vets working in the UK act similarly? And so we can ask the Small Animal Veterinary Association, a SAVSNet, they're an animal health surveillance network, and we can ask them how likely is it that a vet would give antibiotics to a dog with a short history of diarrhea. And somewhat frighteningly, 1 in 2 vets will administer antibiotics for dogs with acute diarrhea. And these numbers have been repeated time and time again, whether it's this study or multiple other studies in the UK, around Europe, and in America. And what they've shown is that one of the biggest drivers for the decision to use antibiotics when an animal has diarrhea is the presence of blood. That can push those rates of antibiotic use up towards 80%. And good studies, randomized controlled trials, have shown that actually there's no need for antibiotics. Those dogs will get better just as quickly without antibiotics. So those numbers should be close to 0 or 1%, nowhere near 50%. This is a situation we can manage very effectively without recourse to antibiotics. And I would say the same about acute vomiting. There's no bacterial cause of that, or very, very rare. So antibiotics would be indicated incredibly rarely for an acute vomiting pet. And cough, similarly, the majority of those are either going to be viral or if they are bacterial, it's only if the animal is systemically unwell that they will require antibiotics. In the Protect Me poster, we do have a gastrointestinal infection section, and you can see at the top there a small highlighted box where we encourage vets to withhold antibiotics, saying if the animal is presenting with acute vomiting or acute diarrhea, that antibiotics are not indicated. And this even applies if you've done a fecal culture and identified the presence of Campylobacter or Salmonella in those feces samples, because we know that those bacterial pathogens are found with very similar frequency in dogs with diarrhea and dogs without, which questions their role. Are they actually just commensals rather than being causative of the clinical signs you're observing? So again, we would discourage antibiotic use in those contexts. We also recommend against antibiotic use for dogs with chronic diarrhea. And historically, antibiotic use has been positioned after diet trials. But we're looking to review that. And currently, we would say, if you have a dog with chronic diarrhea, try a different diet, try a second diet, a third or fourth diet, and then look at ways to support and help the microbiome, the bacteria within our guts, with things like probiotics or prebiotics or even poo transplants, rather than reaching for antibiotics. And this publication that I've put up there, which is an open access one, so you can readily get hold of, highlights that we should reposition antibiotic use further down the chain and keep those for animals where we feel bacteria are playing an important role. When I make these suggestions, vets often are concerned that owners may not be receptive to the decision to withhold antibiotics. And they may say, we've come in, we expected to get antibiotics to make our pet better. Why are you not giving us these drugs? Why are you withholding them? And they're now going to go down the road to one of your colleagues to get what they think is needed to help their pet. So there is a pressure, a perceived pressure at least, on vets to prescribe antibiotics antibiotics for some of these situations. And so we've made a non-prescription form. These also, if you go on the Protect Me poster, there's a little QR code where you can access these forms. It's on the BSAVA website. We'd encourage people to use one. There's also a similar tool available free of charge on the University of Minnesota webpage. What we're trying to do is we're trying to say, reassure those owners, tell them about AMR, about resistance, about antimicrobial stewardship, and they have a role in it as well. So instead of getting antibiotics, you can give them this piece of paper that reminds them you haven't forgotten that antibiotics exist. You are making a conscious decision not to prescribe antibiotics so that that animal can get better without damaging the environment, without increasing that resistance rate. And what you'll see in that, at the bottom of the pad, is some safety netting recommendations. These are designed to encourage owners that if the animal doesn't get better within a few days, or if it gets worse at any point, that they re-present, they come back to you and you can review that decision. But we want them to have that confidence not to need antibiotics after every consultation, because these things work. A non-prescription form reduces the amount of antibiotic handed out during consultations dramatically, and without impacting on patient outcome. That's the key thing. None of us want to prolong suffering, compromise animal welfare. We want those animals to do well. If we believe that antibiotics contributed to that, we would recommend their use. But actually, evidence would suggest that they don't, that they are an unnecessary placebo, and therefore we can manage without, and we need to be open with our clients, with pet owners, and discourage them from taking those antibiotics home. I'm going to present a little case. What you'll notice during this talk is that I jump from different organ systems, and I'm trying to cover as many different clinical cases as possible, or clinical scenarios, while illustrating the different concepts of the Protect Me poster. So Harry's going to help with this. Harry is a little chocolate Labrador. I think he was about 4 or 5 months old by the 5, 6 months old by the time he presented. He'd had a 1-week history of a cough, but otherwise he was quite well. There was no nasal discharge. He's still eating well, and he's growing nicely, and you can see him there playing in the snow. So he's not too bad at this stage. But the owner's worried. They've brought him down to see you. You squeeze his throat, and he coughs and coughs and coughs. So you think he probably has kennel cough. What are you going to do? Are you going to treat him? So have a think. Would you reach for an antibiotic treatment at this stage in little Harry? And if you were going to, which antibiotic would you use? Would you use amoxiclav or doxycycline or enrofloxacin, potentially just sulfonamide? Or, and I'll give it away now, like me, would you withhold the antibiotic for now? Would you say, actually, Harry's quite bright. He's a happy chap at the moment. He's got a bit of a sore throat, but he's coping well with this. Let's check the Protect Me recommendations, and you can see that for kennel cough, it says you can treat with antibiotics, but really only once those signs have persisted for longer than 10 days, or if Harry was unwell, and he wasn't at presentation. So I think it's reasonable at this stage to say Harry doesn't need antibiotics. I'm going to hold off those, keep him away from other dogs because he might have a contagious problem, and maybe give him some anti-inflammatory to make him a bit more comfortable. But I don't think he needs antibiotics just yet. And just so you're aware, the Protect Me guidelines are based on available evidence, where possible, or from consensus statements, such as this one from ISCAID, which is their recommendations as to how to manage dogs and cats with respiratory tract disease. back to Harry. Harry, you can see, well, he keeps coughing, and we're 2 weeks in now. He's still coughing, and at this stage, he's a bit down and subdued. So the owner brings him back. He's a bit frustrated that his dog's not getting any better, and under a little bit of duress, you say, right, okay, we're going to give him some antibiotic. And on this occasion, he was given cephalexin, 20 milligrams per kilogram. If anyone's really quick off the mark, they may say, well, that's a bad antibiotic choice. And I would always encourage you to think, what are you treating? What bacteria do we think that Harry probably has? We're not able to be certain in these cases, but we can say the most likely bacteria, if we truly believe bacteria are involved, is going to be Bordetella bronchoseptica. That's the most common bacterial cause of a kennel cough. So if we think that, we should choose an antibiotic that is likely to be effective against that particular bacteria. And actually, Bordetella is intrinsically resistant to cephalosporins. So that was a bad choice of antibiotic on that occasion. We want to make sure we pick an antibiotic that is going to work against the most likely bug that we were going to encounter. The other thing that we might consider is, will that particular antibiotic get to where I want it to? So if you were treating a dog with prostatitis and you thought, well, I need an antibiotic that will get through that blood prostate barrier. So on that occasion, amoxiclav would be about to amoxiclav. You would want to choose an antibiotic that will get into the prostate, and that would be a potentiated sulfonamide or a fluoroquinolone like enrofloxacin or marbofloxacin. So again, thinking carefully about the antibiotics we use can ensure that we do select the right antibiotic at the right dose for the right disease process. That's the hallmarks of antimicrobial stewardship. So, poor little Harry, being treated now with some antibiotics, but he continues to cough. And we're sort of saying, what are we going to do now? It's 3-4 weeks into the disease process. He's pretty miserable at this stage, and we're worried about him. And these are the opportunities. Can we try and understand a little bit more about this disease process? Can we get more information to make sure our treatment is appropriate? So if you are starting to think, right, I'm going for my second antibiotic or a long course of antibiotic, please do see, is there any way you could get some samples, do some testing that proves the need for those antibiotics? So you could reach for further antibiotic therapy. You could say, I've just heard that Bordetella's resistant to most cephalosporins, so why not just change to a different antibiotic? Well, you could do that. It would be brave, I think, to trial steroids at this stage because we're still worried he might have an infectious etiology. So could you do some imaging to demonstrate the nature of his respiratory disease? Or could you potentially collect some samples that might inform you as to what you're dealing with? And that's what we really should be doing as often as we can when we are thinking about using antibiotics. So if you are going to treat an ear infection in a dog or a skin infection, can you get a sample from that site to demonstrate the involvement of bacteria and the need for antibiotics? If you're treating a urinary tract infection, find the first time, but maybe after that to demonstrate, maybe essentially on, not surprising, actively treat better. Had been worked up, and then the antibiotic choice could be guided to what we knew we should be treating. So from the one end of the dog to the other end, I'm now going to switch and talk about urinary tract disease. Urinary tract disease can present in a variety of different ways. But one of the silent ways that it can present is when you send in a urine sample, maybe for a dog or a cat with another problem, maybe with a diabetic animal or an animal with chronic kidney disease, but they've got no urinary tract signs. They're not showing pollakiuria, dysuria, or hematuria. So do they have a problem in that area? Probably not. If that is the case, they are described as subclinical bacteriuria. So if you do grow bacteria in those situations, interpret it with caution. Just because you found bacteria doesn't mean you need to treat them, because if they're not causing a problem, we can ignore them. And so subclinical bacteriuria, bacteria found without evidence of an active infection, can be safely ignored. No treatment is warranted in those cases. But that's happily quite rare, and more commonly what we are doing is we are seeing animals with lower urinary tract signs. Now this might be the pollakiuria, so going to the toilet more frequently, dysuria, struggling to go to the toilet, or hematuria, blood in the urine. And if it's a female dog showing these signs, there's quite a good probability that they have a urinary tract infection. In fact, arguably, it's probably in the 60 to 70% range. So quite likely that that dog has a urinary tract infection and could benefit from antibiotics. So in those situations, empiric therapy would be appropriate. So healthy, non-pregnant females or neutered males showing the classic lower urinary tract signs could benefit from antibiotic therapy. Now, you may say, I want to be sure that I'm treating, and until I get the result, I'm going to hold off. And that's defendable. But personally, I would say often we will treat those with a bit of either amoxicillin clavulanate, or a potentiated sulfonamide. So that's a straightforward decision. I'm going to pick an antibiotic, and I'm going to make that animal better. But another question, how long are you going to treat that for? So what's your treatment duration? And let's imagine ourselves in this scenario. We've got a female dog, sporadic, uncomplicated cystitis. She's been straining for the last couple of days only, presented to you. You're fairly sure it's got cystitis. You might even do a quick in-house examination and see bacteria in the urine. So you've made a decision and you're going to give them some amoxicillin clavulanate. How long are you going to give it for? Are you going to give them a 3-day course, a 5-day course, 7 days, 10 days, 14 days? Anything in particular? Do you have your own system to define course length? Oops. And what do you base that decision on? So you might say, I'm using 5 days because I've got 5 fingers on my hand. Or 7 days because there's 7 days in a week. Or because there's 10 tablets in a packet. You might say, I've previously managed some of these and they seem to all get better in a week, so that's what I'm sticking with. But surely we can do better than that. Surely we can use science to define what that optimal duration should be. And this is something that is painfully lacking in veterinary medicine at the moment. We don't have good evidence supporting any duration for any of the treatments that we're using. So it's nearly always, how long are we going to go for? Well, a week will do. But we can do better than that, because if 3 days is as good as a week, we could halve the amount of antibiotic we're using, half the likelihood that we're going to generate resistance. So in human medicine, a brilliant chap called Brad Spellberg has put together a whole table of randomized controlled trials comparing short with long courses of antibiotics. And this is for a variety of different conditions. So don't need to worry about them all, but the first one, community-acquired pneumonia. Down here, you've got urinary tract infections or pyelonephritis. Here we've got osteomyelitis. And if we look at the osteomyelitis, we can see that a 42-day course has been compared with an 84-day antibiotic course and found to be exactly the same in terms of patient outcome. So bad luck if you were in the 84-day treatment arm because you had 6 weeks extra unnecessary antibiotics. And you can see that in this table, time and time again, the shorter course has been shown to be just as good as the longer course in terms of helping those people get better. So can we reflect on, do we really need to keep those antibiotics going for as long as we have been, or can we bring those course lengths down? We are trying to work this out and to generate a similar table to Brad Spellberg's table for veterinary medicine. So this is a trial that we're running at the moment. It's called the Stop on Sunday trial. What we're doing is we're taking dogs seen any day, Monday to Friday, and we're saying, with cystitis, we're saying, here's your antibiotic course. It finishes on Sunday. So if they come in on a Monday, they get a 7-day course. If they come in on a Wednesday, they get a 5-day course. If they come in on a Friday, they get a 3-day course. And we're trying to see, does it make any difference to patient outcome? If they get better, whatever day of the week they come in, then chances are it doesn't matter how long that course is, as long as it's 3 days or above, that will be fine. And we can encourage vets to bring that down if we find that the minimum effective course duration. So that study is ongoing. I hope to have some of the results of that probably by 2026. So one more subject and then on to a little bit to wrap it up. This is surgery. And I'm sure I'm a medic, so I happily don't have to do very much surgery these days. I'm not sure I'd be allowed to anyway. The use of antibiotics around surgery accounts for a lot of antibiotic use. And the majority of that use is to treat an infection that isn't there. It's prophylactic use. It's being used to prevent an infection developing. But can we not find other ways to prevent that? Washing our hands before the surgery, wearing gloves, good Halstead principles, surgical asepsis. These are the things that will prevent a surgical site infection. I don't think we need antibiotics for all of these instances. Now, there might be situations where perioperative antibiotics, a single injection or a couple of injections of antibiotic just before and during some procedures, for example, an enterectomy or orthopedic surgery with an implant, could be appropriate. But how many of these types of surgery need to leave the practice with a course of antibiotics? You've done the procedure, you've sewn the animal back up again, they're all fixed. Do they still need antibiotics for another week at home? I would argue that none of these do. Now, excuse the one at the bottom, number 8. That's septic peritonitis. Now, that's an animal with an infection. So that isn't prophylactic use. That would be therapeutic use, using an antibiotic to treat an infection. All the others, there is no evidence of infection, so it's prophylactic use, and arguably, once the procedure is complete, that antibiotic is not required, and I would monitor them closely and see if we can get away without using antibiotics prophylactically. Now, it's a bold recommendation. It does feature in the Protect Me poster, but it's going to take a while for that for surgeons to have the confidence to hold off using antibiotics. I would love more surgeons to try this. See if you can do these procedures where historically you've given them antibiotics to go home with. Try not doing that and see how you get on. We would really love to hear your experiences and see whether you can manage those things effectively without antibiotics. I've put in some findings from Australia, and they've shown that actually antibiotic use is still very common for procedures such as dentals, castrations, spays, and arguably they require no antibiotic at all, not even perioperative antibiotics. So those we could do a lot better by withholding all antibiotics from them. So, last few points. One of the key stakeholders when we are talking to vets, they say, hang on, we understand this message, we're on your side, we want to do the right thing for pets and for the environment and for One Health. But it's the owners who are the problem. And we're struggling to convince the owners. So we wanted to find a way to try and improve awareness among pet owners and to encourage them to be part of the solution. And so we created an animation. It was done by the brilliant Emma Wright, pictured here. And we showed that we could change owner attitudes just through watching this little video. Now, I'm not sure if you can't hear it very well, put your hands up and we'll move on. But I'll show just a 30 seconds of this and see how we get on.
I'm Emma the vet. How can I help Dottie today?
Dottie had diarrhea this morning on her walk.
I think she needs some antibiotics.
Let's examine Dottie and work out how to make her better. Our bodies contain many bacteria. Some of these are helpful, while others can be harmful and cause disease. Luckily, we have antibiotics to treat bacterial infections. But you might have heard about antibiotic resistance. Bacteria can become resistant, meaning antibiotics no longer work. The more we use them, the sooner this will happen. Common bacterial infections could kill our pets and our loved ones. Antibiotics may also cause side effects and damage helpful bacteria. Many conditions get better without needing them. Only using antibiotics when necessary will ensure they work in the future. So, only use antibiotics if your vet prescribes them. Let's choose other options to treat our pets when we can. I think Dottie will get better in a few days with a bland diet. She doesn't need antibiotics today.
That's good news.
What can you do? Remember, antibiotics won't help many conditions, including sickness, diarrhea, or sneezing. Be a responsible antibiotic steward, follow your vet's advice, and help keep antibiotics working for when they are really needed.
Okay. So lots of the things that were covered in that video are familiar. So I've said a lot of them already today. That's designed in language for pet owners. We have translated that now into 20 different languages. Unfortunately, not Indonesian yet. But it is accessible, it's freely available. And what we showed is that owners that watched that video, their attitudes changed within the 2 minutes. They were less likely to ask for antibiotics and they had greater awareness of AMR and multi-drug resistance. So we can do more just by showing that. And you could put it up in the waiting room saying the vet's running a little bit late. Why not watch this video? And then hopefully they will understand when you say, I don't think you need antibiotics for your pet today. And that's the publication that went with the with that article, with that animation. Everything I've talked about so far is an example of enablement stewardship. What that means is that we are making guidelines, we are making recommendations or suggestions to vets, encouraging them to do the right thing for the right reason. But in some countries, in a lot of countries, you can ignore those recommendations. You can say, I would like to use antibiotics and I'm going to use 3 weeks worth antibiotics to treat this acute diarrhea. And it is your right to do that as a prescriber in a lot of places. But that right, or those uses, will change as new legislation is being introduced. And this has already occurred across Europe, where they're much more stringent about the antibiotics you can use and the ways that you use them. And this is going to have big repercussions for the way that we access antibiotics in the future. Already, it has changed the pattern of antibiotic use in France and Germany. We've shown that. So we need to be careful that if we don't demonstrate that as vets, we can be appropriate custodians of antibiotics, they will be taken away from us. And antibiotics are classed differently according to their importance to human health. And we want to make sure that if they are classed as more important ones, well, actually, they are not used routinely. So drugs like vancomycin, imipenem, they should not be on vet shelves at all. They should really be reserved for human-only use. And drugs like the fluoroquinolones or the third-generation cephalosporins, they also should be kept for really dire emergency situations. They should not be our first-line antibiotic in any situation. It's really, really important. And then just to finish off then, one last bit about what happens when you end up with antibiotics left over. So you've prescribed your 10-day course of antibiotics, but the pet got better after a few days, so they didn't need the antibiotics. Well, this happens more commonly than you might think. And in human medicine, about 1 in 6 people have leftover antibiotics after any particular course. And frighteningly, very few of them return them back to the pharmacy. Lots of people think, well, I'll just throw them away, either in household waste or down the toilet. But that leads to environmental pollution, and it will drive up AMR. We've done a really good job reducing the amount of antibiotic we're using, but then we're throwing the pure stuff into the bin or down the toilet, causing multi-drug resistance. And a third of people actually keep them to become their own doctor's practice and use them themselves the next time they get ill. We want to stop that as well. So we've set up the antibiotic amnesty. This was an opportunity for pet owners and human patients to return unused leftover antibiotics to their pharmacy or to their veterinary practice for safe disposal. And we've been encouraging that throughout November for the last few years. Because if owners are more aware of this, if people are more aware of this, they will do the right thing. So we would encourage that. You can see on the screen there a little QR code. I'd be very grateful for any help and answers to see what goes on in different countries. This is a global study being run by the WSAVA Therapeutics Committee at the moment, and we're really keen to understand what are the different practices around the world relating to antibiotic disposal. Because if we find that there are some areas where things aren't happening perfectly, well, maybe we can offer targeted guidance, we can support vets to improve the way antibiotics are disposed of. So if you do have a few minutes, it's a very quick survey. I'd be very grateful for any support in completing that particular and helping with that research. In conclusion, use of antibiotics is crucially important, and we are really keen to encourage as many vets as possible to become an antibiotic steward, become an antibiotic guardian, and make sure that you use antibiotics in a way that will help preserve their efficacy for the future, reducing the threat to animal health and to human health from antimicrobial resistance. There are lots of different ways that you can get involved in this, including getting your own copy of the Protect Me poster and putting that up on your practice wall. Maybe thinking about ways such as the Stop on Sunday trial. Could you change the way, the duration of antibiotics that you use? Think about incorporating that video in your practice. So could you provide owners with some information that will reduce the likelihood that they'll ask you for antibiotics? I've mentioned the antibiotic amnesty, and any help with that survey would be greatly appreciated. And there's a second survey here. This is a couple of clinical scenarios that we're putting out to vets, and we're asking vets around the world, how do you approach different clinical situations? So again, if you've got a little bit of time later on today, any help with this survey would also be gratefully received. I really appreciate your time today and the opportunity to speak to everybody. If there are any questions, I'll happily take them in a moment. If anyone's got any questions later down the line, please feel free to send me an email. My address is at the bottom there, and I will do my best to get back to you as soon as I can. I do hope that everyone is enthused as much as I am by this idea of antimicrobial stewardship and the opportunity that we have as prescribers to make a difference. It's going to take all of us working hard, but together we can achieve big things by optimizing the way we use antibiotics. Thank you very much.
Thank you very much, Dr. Fergus. Awesome presentation. So very powerful and insightful for us. Actually, I know a couple of friends of mine. They are excited and they want to contribute in reducing the use of antimicrobials, but they just don't know how, and they just don't know where to start. As some of them are just junior in their practice, so they're asking me, and we got some of the answer from your presentation today, and including your example about how human is using antibiotic so sparingly, like a child, they withhold the antibiotics from the child, and it's like how like we're seeing in the mirror how we vets are giving away the antibiotics like too easily to our patients. So it's wow, it's really opening my eyes, and I hope it's also opening the other participants, and maybe we can try some of your advice in our clinics. Okay.
I hope so. And I think to demonstrate that something is working, you can audit it. So you can say, in 2024, I saw this number of dogs with diarrhea. How many of them did I give an antibiotic to? And then in 2025, because I'm now going to try not to, how many dogs did I see and how many did I treat with antibiotics? And hopefully you can reduce those numbers and you can see that improvement. And you can also track whether it has any impact on patient outcome or owner satisfaction. So you can look at these different things and maybe choose one area that you think you could improve to start with. So I understand this sort of the worry that this is such a big subject. How can I do everything? How can I make sure I get it right? Well, no one can achieve that in one day. you maybe need to start, well, what's an area where we use antibiotics too frequently in our practice? And it might be diarrhea, but it might be cat bite abscesses. Do they all need antibiotics, or could we start managing without? And if we are using antibiotics, do we use this long-acting third generation cephalosporin, or do we use a simpler drug? So you can have those conversations. I'm a believer in a practice meeting, an opportunity to take the Protect Me poster, put it on the table and say, let's focus on this particular section today and see if we can improve the way we treat those particular conditions. And then we'll come back to each other in 3 months or 6 months' time and say, how did you get on not using antibiotics for that? And hopefully people will say, yeah, it's worked, it's been fine. And actually, let's keep doing that. So Rome wasn't built in a day. That's the phrase, isn't it? We can take it in a step-by-step approach. Making little changes will build up to a big benefit in the long term. But I'm really enthused by the fact that your colleagues are so excited by this area.
That's such a good idea. If we trace our how we reduce our antibiotics, maybe like a Spotify recap, we can really count how much antibiotics that we spare and how many patients are safe without antibiotics. That's really awesome.
Absolutely. And you may not be aware of, there's a charity arm of the Royal College of Veterinary Surgeons called FRCVS Knowledge. Every year they run an antibiotic award program based on auditing. So if you do go to the effort to audit your antibiotic use, you put in place policies to change and improve the way that you use them, then please apply for an RCVS Knowledge Antibiotic Guardian Award, and that will recognize your efforts and encourage you to keep doing that. So there are opportunities. This is something that we are really trying to encourage vets to engage with.
Okay, that's good. So we can get more encouragement when we do step by step.
Absolutely.
Okay, let's start with the question session, shall we?
Yeah.
Okay. First question comes from Dr. Ayu Kodunisa. Okay, I will read it for you. Thank you, Dr. Fergus. I want to ask your advice. If the patient have increased or decreased weight while in antibiotic, do we need to adjust the dose based on the current weight, or we just stay with the first dose?
So in my experience, antibiotic use should really be short-limited. So it shouldn't be, this question should rarely arise that there will be a significant weight change during an antibiotic course. Personally, I don't believe there are many indications outside of tuberculosis. We do treat TB occasionally in cats, but other than that, there are very few indications for long-term antibiotic use. So hopefully this will be a rare problem, but if it is occurring, if you do notice a significant weight change in the animal, yes, please do adapt the dose. The dose of any antibiotic should be the most effective dose. And often that's going to be towards the high end of the dose range. So, for example, if I was using enrofloxacin in a dog, I would often treat at double the standard dose. So getting on for 10 milligrams per kilogram rather than the standard 5 milligrams per kilogram. That's because we know it is more effective at against certain bacteria at those higher concentrations. Now, just as a quick reminder, never use enrofloxacin in cats. It can cause blindness. But in dogs, if I was using it, I would use it at a double dose. And I would try and dose it according to the most recent weight I have for that animal.
Okay, thank you for the answer. That's such a good question. And that's reminding me, I want to ask regarding the topic. Do we really need to adjust the dose when we giving it orally, then intravenously, or we should to give the orally higher dose, maybe?
Rarely. So we're still learning a little bit about this, and there will be some changes, I think, in the way that we recommend dosing of antibiotics. But currently, the guidance is use the dose, the same IV and orally. If we take amoxiclav as an example, then the IV dose is standard around 20 milligrams per kilogram, 3 times a day. I would use a similar dose orally. So I would go for higher doses than maybe the label would suggest for some of these administrations, because that is more likely to be effective. The only thing limiting higher doses of antibiotics is often tolerance of those antibiotics. So you don't want to go too high because it might cause vomiting or diarrhea, but equally you want to make sure it's effective. So higher doses tend to be better in most situations.
Okay, so we should aim for the higher dose and for the most effective dose. Okay,
most effective dose. Yeah.
Okay, next question from Dr. Ardana Ruti. Thank you for tonight education. Some owner use drugs non-fat in their community by the YouTube videos. Okay, how to deal with the owners like this, aside of educating?
So luckily in the UK, you can only get antibiotics for animals from a vet. And I appreciate that's not the situation everywhere in the world. And this is a challenge. I do believe it comes down to education. And that's why I showed that little video. And I think that the more we can engage with pet owners and we can stress the importance, not just for their animals' health, but for their own health as well, of using antibiotics rationally and sensibly in every situation, the greater the chance that we can actually get them on our side. I think it is absolutely a great idea to make some sort of seminar for pet owners and providing them with education, whether it's via a poster, via a YouTube video, via a little animation like we did. I would fully encourage. I think we need to spread the word about the importance of AMR. We are the big users, or some of the big users of antibiotics in the veterinary profession. We want to be standard bearers for doing this the right way and support the community so that we can keep these things efficient for when we need them. So when I'm in hospital and I've got a broken leg or I need a new hip or whatever goes wrong with me, I would like an antibiotic that is going to work. And I will be frustrated if it doesn't work because I've been using it too often to treat diarrhea in dogs. So between us all, we have to get this right. We have to make sure we only use antibiotics when they're needed so that they will work when they're needed.
Okay, thank you. So we can expect Dr. Ardana will create some posters for the non-fats, and maybe we can collaborate with AKIVI. We are open for the collaboration. We should educate more. Okay,
Brilliant.
thank you. Next from Dr. Lenny. This is my teacher, actually, from my professor. Okay, thank you so much for the presentation. She would like to ask, Indonesia is a tropical country which parasites and bacteria can grow easily, maybe more than the European. We worry so much about the secondary bacterial infection. What do you think about it? Shall we make?
Yeah. Well, let's do one question at a time. I think
Okay.
I have to accept that the UK is not a tropical country. We are the opposite of that. Though it is very rainy today, it's also always very cold. And so we do have a different environment for bacterial growth. But actually, most bacterial growth is occurring on the organism. And animals have survived for many thousands, millions of years because they can fight off infections. So I think that it's it's probably not as great a risk as we make out that bacteria will overgrow or flourish because of the surrounding environment. They will flourish if we don't provide the animal with a healthy environment. So if you have a dog who is living in poor hygienic circumstances, then that increases the risk of an infectious disease process. But if they are unwell, let's try and keep them in a hospital environment. Let's make them better. And I'm not convinced that it's the ambient temperature alone that will impact their susceptibility to infection. So I would hope that we can treat them still effectively, and we don't need to reach for antibiotics to cover for secondary bacterial infections. You're very right about sort of tick-borne disease and parasitic disease, which can compromise the immune system. And so an awareness of the parasites and those organisms that are common in your environment can help early identification of these, preventative treatments to reduce their incidence, and adapted treatment when they do occur. So yes, there will be situations where if you do get a tick-borne parasite, you may need to use an antibiotic to rid that animal of that, but I don't think it's a reason for empiric antibiotic use without good confidence of the need. But
Okay.
I do think, and that the last point, do you need to make regulations policy for use in your country? 100% yes. Really, really, I strongly encourage that. I don't know. Well, I've never been to Indonesia, so I know so little about it that I would not be the right person to advise you in all the situations that you see. We would love for Protect Me to be a skeleton guide. It's the best we could come up with for the UK. We are giving it out to anyone in the world who would like to use it. But if you can adapt it, if you can make it relevant to the animals that you see, the disease conditions that you face more commonly, then it's going to be much, much more impactful than relying on a document made for a UK vet population. So please do use it in any way that it can be useful, but adapt it, make it yours, make national guidance, and we will try. I mean, in the community that I work in terms of antimicrobial stewardship, there are a lot of people who are eager to contribute to different guidelines. So Scott Weiss, who's over at the University of Guelph in Canada, has developed the First Line app, which you can download on your phone. And that provides guidance already. He is keen for that to be taken on by other countries. And so if you wanted to speak to Scott and say, could we make an Indonesian version of that? I'm sure he would be open to those type of things. But 100%, please do make them country specific. They will be much, much more likely to be effective in that scenario.
Okay. We get really excited veterinarians. They asking a lot of questions in the below. Okay, maybe the second and the third question is how about the long time usage of the antibiotics? And the last one is how to encourage to use to do the culture.
So in terms of rickettsial infection, then yes, your colleague's quite right that probably a 3-week course is often standard for things like Ehrlichia. My knowledge of some of the what I consider exotic disease processes is quite sketchy. So I would refer to common textbooks as to how long you should be using. I think though those numbers are probably made up, i.e. someone thought, well, let's try 6 weeks and started on that. Challenge it. Set up a study. Offer half of your cohort 6 weeks and half of them 3 weeks and see if there is a difference in outcome. Prove the need for those longer courses. Be part of that citizen science and try and establish with evidence the need for a certain length of antibiotics. So I don't know the answer to a lot of those questions. I don't think anybody does. why not try and find the evidence and answer those? And I'd be very happy to support anyone who wanted to do that. And I've read the third question about bacterial culture and susceptibility testing, and I do recognise we have a similar problem in the UK. The price of antibiotics is much less than the price of the diagnostic tests that we're recommending. So how do you square that circle? Well, I think I do talk to owners about effective treatment. I talk to them about a delay in accurate diagnosis can compromise their animal's welfare. So if I miss that this bacteria is resistant to the antibiotic I've chosen blindly, their animal is going to suffer for longer. So we need information to optimize our treatment of their pet. So I do encourage them to do these tests so that I can afford their animal the best treatment available, adapted to what is going on in their pet. So it is having those conversations to explain why we need to do those tests, why we need to do that information. There are situations where empiric treatment is appropriate. If you've got a dog with cystitis, you can bet that it's got a urinary tract infection. I still think it's reasonable to treat that without a culture, at least the first time. But if it's a repeat offender, or if you've been trying it on antibiotics already and it's not getting better in the way that you expect, then you need that information so that you can guide the treatment most effectively.
Okay, thank you so much for the answer. Okay, that's Dr. Lenny. Next, I want to point out the question from Dr. Muhammad.
Yep.
He said that from the presentation, the shorter are better. But what about the doses?
High doses.
The low dose?
High doses. No, I would prefer the high doses. So as we said earlier, I think that we want to make sure that the dose is effective. And typically that is going to be the higher end of the dosing range. So provided the high dose is tolerated by that particular animal, I would tend to go with high doses. One exception to that is metronidazole. I don't know if you use much metronidazole, but it's very commonly used for gastrointestinal disease in the UK and in Europe. And we have shown that it causes neurotoxicity when used at the high end of the dose range. So if I was using metronidazole, and honestly, I hardly ever do, but if I was, I would be using that at 10 milligrams per kilogram twice daily, even though the dose range goes up to 30, 33 milligrams per kilogram twice daily. I would always stay low with metronidazole, but for other medications like the beta-lactams, so amoxicillin, amoxiclav, or the fluoroquinolones, I tend to go towards the high end of the dose range.
Okay. Oh, that's the metronidazole is very nasty with the a longer diarrhea after the metronidazole. Okay. Maybe the third question. The myth about the higher antibiotics.
Okay. So, well, I'm just going to jump onto question 2 as well, because I like the idea of topical antibiotic use. And yes, unfortunately, it does contribute, but less than systemic use. Systemic use, if you take a tablet to treat an ear infection, yes, it will get to the ear, but it gets to the whole of the body as well. And any bacteria in the gut will be affected. And there could be resistance developing among our commensals. So if you can put the antibiotic where the infection is, it is going to be much more effective and have a lower impact on driving resistance. So I'm fully in favor of topical use wherever possible. Same for eye treatments as well. And for antibiotic, the tiering is to try and it's related to their importance to human use. So if you can select a low tier antibiotic, that is going to have less impact should resistance arise. It may be that you do, as you said, that you may end up on high tier antibiotics, but it's still preferable to use a low tier antibiotic in whenever you anticipate that it will be effective. So if I could choose between using a potentiated sulfonamide or a fluoroquinolone, and they have similar spectrum of activity, then I would prefer to use a potentiated sulfonamide. So trimethoprim sulfonamide would be a good treatment for prostatitis if I had it available.
Okay, as you said, what we choose is based on the location also and the type of bacteria.
Yep, absolutely.
Not only the tire, but also the type of antibiotics. Okay, next maybe from the Dr. Intan, case study about her patient that diagnosed with KCS and positive with the virus. Given levofloxacin more than 7 days. Okay.
So I'm not an ophthalmologist, so I'm always a little bit nervous about offering ocular advice. But conjunctivitis, I'm encouraging topical use for that. You've highlighted both I'm guessing some bacterial involvement, but also some viral involvement, and some protozoal involvement there. I'm not sure of the relevance of Giardia in that context, and so that would be slightly unusual, I'd have thought, as an ocular pathogen. But you can, I think, when you feel that the treatment hasn't worked, I would review whether that's because the treatment, there is resistance to that particular molecule, or whether it is a non-bacterial etiology. And we see a lot of conjunctivitis that is non-bacterial. If it's viral, then there is going to be no impact from any antibiotic. It just won't make a difference. Could it be allergic? So we see animals with allergic sort of hay fever-like disease. So could they require steroid drops rather than antibiotic drops? So I think it is a case where rather than just switching antibiotic, I would encourage a careful review of the case to see what is going on. Is there a bacteria there, and will it respond to a particular antibiotic? But if there is, then yes, you are right, and you may need to switch. And then rather than using the same class of antibiotic, so if you've had a failure from one fluoroquinolone, switching to a completely different class of antibiotic is probably going to be a better option. So I think there are some good chloramphenicol eye drops that we often use in that context.
Okay, thank you so much. Maybe it's been a fun fun session. Maybe last two questions. Is it okay?
Yeah, that's fine.
Okay. Okay, from Dr. Gyandra. He's also a lecturer. Okay, maybe first about your case study about Harry.
So it's a great question, and I should say that I presented it as though Harry had come to see me. He came to his primary care vet, and so that information was taken from the clinical records. And I think you're right that a culture swab could have been performed at that first presentation, but it is trying to balance the need to know what we're dealing with and the cost to the client. And unfortunately, culture swabs and collecting them from the back of the throat can be challenging. They can cost a significant amount of money, and it's trying to be pragmatic. Would that change the way we manage Harry in that first instance? Probably not. We're anticipating that the vast majority, probably 90% of dogs like Harry, will get better without needing anything more. So we should be able to avoid the need for either antibiotic treatment or even for diagnostic investigation. I think if you could do it quickly and cheaply, yes, I would always do it. But if and have the conversation with the owners, certainly, but it's not unreasonable to say, I think he's got this. I'm making a diagnosis based on a clinical syndrome, the presenting signs, and therefore I'm going to make a guess, and it is a best guess, an informed guess, and rely on that initially rather than doing tests that the owner finds expensive. So it's trying to mention that.
Yeah. The second one is about the Protect Me protocols.
Yeah, so the protocols are just the protocols. They are. I'm not the only person who came up with the Protect Me poster. It was a group of vets and specialist vets who sat around trying to come up with these recommendations. They aren't appropriate to every single situation, and there may be situations where you say, actually, this dog has diarrhea, but he's also showing signs of sepsis. So he now needs antibiotics, and I would agree with that. Okay, if they're properly poorly, then antibiotics can be necessary. So there will be situations where you deviate from the suggestions on the poster, and that will be perfectly reasonable. What we're trying to encourage is say, in the majority of cases, the recommendations should be applicable. And we're very keen to get feedback where you think, actually, this is a terrible recommendation. In our situation, we are seeing a lot of an infectious cause of this that would need this particular treatment, so the recommendations are not appropriate. Then either, and there is a QR code on the poster, we welcome feedback and we'll try and adjust it and make it better recommendations next time round. Or just scribble on the poster and say, we are changing that recommendation so that in that situation, use this particular approach. It's not perfect. We've done our best with the information that is currently available, but there may be situations where you can improve it based on local knowledge, based on your own experience, etc.
Yes, veterinary medicine is an art. So we're all an artist with our own. We come up with our own colors and brush maybe. Okay. Maybe the last one I want to mention about Dr. Rosalia's question, because there are a whole lot of respiratory cases in Indonesia, especially cats these days.
Yes.
How do you approach the antibiotic?
I think that this is a big challenge because these cats probably have non-specific viral disease. Bacteria do not act as a primary nasal pathogen. So they will cause secondary nose infections, but they don't act on their own. So I suspect that a cat with recurrent upper respiratory tract infections has either calicivirus or herpes virus underlying those signs. And that makes it very, very difficult to clear it, and the antibiotics are unlikely to resolve the problem. Your choice of doxycycline was very, very sensible. So the antibiotic of choice, because the potential for Chlamydia felis to play a role has been recognized. But if you've already treated it and you've not seen much of a difference, I would pull back on the antibiotics. I would say to the owners, this is a really, really frustrating condition, and it probably is not going to go away ever. And as such, you may find yourself having to manage their expectations. Tell them you're going to have a snotty cat. When the snot is really bad, when the cat is poorly and systemically unwell, a short course of anti-inflammatories, so a non-steroidal anti-inflammatory might help. Occasionally some antibiotics if they seem really miserable. But the mainstay of treatment is going to be trying to clear that mucus. So it might be easier in a hot tropical country than it is in the UK, but we advise owners to take their cat upstairs and into the bathroom when the shower's on so that they can inhale some steam. We would use a drug called bisolven, which is a example of bromhexine, a mucolytic designed to break up the snot and make it easier for them to clear that. Those are the things that I think I would rely on, and encouraging vaccination. in other animals so that we can reduce the amount of calicivirus and herpes virus in the population so that this incidence of cat flu goes down. They would be the things I would really encourage.
Okay, thank you so much. It's been a really fun question and answer session. There are a lot of participants that participating, and I hope it clears our misunderstanding about antibiotics. I myself a practitioner, and your advice of to use the antibiotics at the high effective dose is really makes sense, and I think I will try to do it. And I hope with this webinar, Indonesian veterinarian can try more. I think we can try more and have more confidence in our skills, in our judgment about restricting the use of antibiotics. Maybe we can try more, and with this community, including AKIVI, we can encourage more Indonesian veterinarians to restrict the use and to spare the use of antibiotics for the better future for human and animal health. Okay, thank you so much. Maybe kembali ke Dr. Sri Wahyuni.
Baik, terima kasih banyak dok sudah membantu memimpin jalannya diskusi kita pada malam hari ini. Kepada rekan-rekan sejawat, Bapak Ibu dokter hewan, kolega dokter hewan, silahkan men-scan barcode yang sudah disediakan pada kolom chat kita sebagai presentasi kita pada malam hari ini. Untuk acara selanjutnya yaitu pembagian sertifikat dari Ketua AKIVI kepada narasumber kita, pada dokter hewan Nusdianto Trekoso, kami persilahkan untuk memberikan sertifikat penghargaan kepada Dr. Fergus Allerton.
Terima kasih, Dr. Yuni, Dr. Dion, terima kasih. And thank you very much, Dr. Fergus Allerton. From the deepest of my heart, our heart, is very important and very interesting topics for us, for our veterinarian, especially and small animal practice. It's about the use of antibiotics. So please, we want to give an appreciation, after you sharing your knowledge for us, for increase our awareness about the antibiotic uses. I want to sharing and give you an appreciation from our association, so for you as speakers, so please accept. And we send you soon, Dr. Fergus Allerton. Thank you very much. Thank you very much. Terima kasih, Dr. Yuni.
Baik, terima kasih dokter. Mohon izin untuk di akhir sesi setelah kita menutup acara ini untuk mengambil gambar bersama. Jadi agar kiranya kepada seluruh Bapak Ibu kolega dokter hewan yang tergabung dalam acara ini agar membuka kamera.
Ya, silakan.
Mohon izin agar di-mute dulu para dokter. Kita akan mengambil gambar bersama. Baik, terima kasih dengan.
Terima kasih.
Ya. dengan berakhirnya acara kita pada malam hari ini, semoga dapat memberikan banyak manfaat pada kita
Amin.
semua sebagai para kolega dokter hewan dan sebagai praktisioner yang kerap kali menggunakan antibiotik dalam pengobatan sehari-hari. Terima kasih banyak juga kami sampaikan kepada narasumber kita, Dr. Fergus Allerton, thank you very much, dan seluruh pihak yang telah terlibat dalam dan berkontribusi dalam terselenggaranya acara kita pada malam hari ini. Akhir kata, selamat malam dan sampai jumpa pada kesempatan berikutnya. Semoga rekan-rekan sekalian bersedia untuk mengikuti kegiatan-kegiatan AKIVI selanjutnya. Selamat malam, wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Ya, terima kasih sudah bergabung dengan kegiatan kami. Yeah. Thank you very much, Dr. Fergus. Don't be dated with our program, next program in AKIVI. Yeah.
Dok Nus, kita tidak ada sesi foto bersama ya?
Sudah, tuh barusan.
Oh, sudah ya?
Sudah,
Oke,
di
berarti
foto Dr.
saya
Yuni.
lagi ke belakang
boleh
nih.
diulang aja dok,
Ulang
biar semuanya bergabung.
Thank you so much, Dr. Fergus Allerton, for the answer. It's a very, very nice answer. Terima kasih Dok Deon, terima kasih Dok Sri Wahyuni, dan terima kasih Dok Nus.
Terima kasih sama-sama.
Ya. Apakah ini sudah selesai, Dok?
Sampun sudah selesai.
Sampun.
Iya.
Baik, itu. And nice to see you, Dr. Allerton.
Saya ini sedang di luar kota ini. Kebetulan di Blitar.
Luar biasa sekali ya.
Besok acara di Tulungagung soal besok.
Oh, I see.
I'm gonna have to nip out to another meeting. So thank you ever so much.
Thank you very much. Thank you very much, Dr.
Take care.
Fergus. Please, thank you. Yeah.
Thank you. Bye.
Goodbye. Kita tutup ya. Terima kasih Dr. Deon.
Terima
Baik
kasih.
Dok, saya mohon izin live juga. Terima kasih Dok Deon. Bye.
Terima kasih.